Hello everyone, hope you're all doing great. In this video, we are going to discuss about cephalopelvic disproportion. So, cephalopelvic disproportion. So, from this term itself, you'll be able to understand that there is some disparity between the fetal head and the maternal pelvis, right? So, however, the presenting part is going to be the head of the fetus, okay. This kind of cephalopelvic disproportion is going to be associated most commonly with obstructed labor, but there is problem in the labor alone. There is no problem during antenatal period. You have to understand this point, okay. Antenatal period, there is no problem, there is only problem during labor. Clear? Yes. We'll check on to the next one. So, what are the causes of this cephalopelvic disproportion? See, there are numerous causes, okay. I'll try to make it as much as easy for you, but anyhow, the causes are all very important. So, we'll see why the maternal pelvis is going to be small. See, the maternal pelvic diameters can be reduced at various levels of the pelvis, okay. So, then it is considered as contracted pelvis. So, here the diameters are going to be less than normal. The diameters at the inlet, namely the AP diameter, can be less than 10 centimeters, transverse diameter can be less than 12 centimeters, and then diagonal diameter can be less than 11 centimeters. And in the midpelvis, the diameter of interspinous distance is going to be less than 8 centimeters, and at the outlet we have a similar diameter, namely intertuberous diameter. So, this diameter will also be less than or equal to 8 centimeter. So, in all these cases, if there is reduction in the level of diameters at various levels, namely the inlet, midpelvis or outlet, then it is going to be called as contracted pelvis. Clear? Then we will see the pelvis type. So, these are the 4 types of pelvis we have, right? So, it is going to be the gynecoid, android, anthropoid and platypeloid pelvis. So, if we take gynecoid pelvis, in this type of pelvis, the labor is going to be normal, okay. So, there is no problem at all. When we take android pelvis, okay, android pelvis is most commonly having a converging side walls. You are able to see, right? The side walls are going to converge here. So, it is going to be associated with prolonged or obstructed labor. So, most of the times deep transverse arrest and persistent occipito-posterior position are also associated with this, right? And then you have the anteroposteriorly oval anthropoid pelvis, okay. So, this pelvis is associated with phase 2 pubis delivery, clear? And the 4th type of pelvis is transversely oval pelvis. You are able to see this, it is transversely oval. So, that means it is having a small anteroposterior diameter, okay. So, here there can be chances of asymptotism and there can be chances of transverse arrest also, clear? Now, we will see about the 2 types of asymptotism. We have the anterior asymptotism, or it is also known as Neagley's asymptotism. It is an, A for N, okay, Neagley's asymptotism. And then we have the posterior asymptotism or Litzmann's asymptotism, okay. So, we know very well that we have already discussed, right. So, in anterior asymptotism, the anterior parietal bone presence, whereas in posterior asymptotism, posterior parietal bone presence. And then if you take the position of sagittal suture is near the sacrum in anterior asymphysis, whereas sagittal suture is towards the pubic symphysis in posterior asymphysis. Then anterior asymphysis will be favorable for delivery, whereas posterior asymphysis is not favorable. Clear? Right. We will see the other causes. Okay, still we are seeing the causes for cephalopelvic disproportion. Okay. So, there can be chances of abnormal pelvis also. Okay. So, due to developmental causes, there can be absence of both ala of sacrum. Okay. So, both ala of sacrum absent. What will be called as? Will be called as? Yes, very good. It is Robert's pelvis. And when only one ala of sacrum is absent, then it is known as Neagley's pelvis. So, this is the picture that is showing the abnormality in pelvis. So, here if you see, you are not able to see both ala of the sacrum. So, it will be known as, yes, Robert's pelvis. And here you are able to see only one ala of the sacrum is absent, right. So, it will be called as Neagley's pelvis, right. Then we will pass on to another important concept, that is cephalopelvic disproportion can also happen in high assimilation of pelvis. See, what does this high assimilation of pelvis means? The pelvis will be having a higher level of inclination. That means what happens is the last lumbar vertebra will also be included into the sacral vertebra. Clear? So, last lumbar vertebrae included or incorporated into the sacrum. So, what happens because of this? The sacral promontory will be at a higher level. Okay. So, this higher level of inclination can lead to lordosis or pendulous abdomen. Clear? And sometimes even low assimilation of pelvis can also be there. So, low assimilation of pelvis can also be there, where you have only 4 sacral bones, okay, but here it is not that much obstetrically significant. Clear? Only high assimilation of pelvis is significant, where you can have cephalopelvic disproportion. Clear? Yes. Next we will see the other causes like deformities that can lead to cephalopelvic disproportion. These can include rickets, osteomalacia, kyphosis, scoliosis and spondylolisthesis. Clear? Next one is about the infections that can lead to some damage in the pelvic walls, like or the hip joint. Okay, so it can be poliomyelitis or tuberculosis, or there can be trauma to the pelvis by road traffic accident, or there can be an accidental fall, or surgery to the lower limbs. Pelvic bone tumors can also be there, for example, chondroma or osteoma. Then pelvic soft tissue tumors. Okay. So, soft tissue tumors, say there can be a fibroid or an ovarian cyst. So, let's see what about the history. Okay, suppose if the patient has a history of prolonged labor, or she had a history of instrumental delivery or cesarean section without any cause, okay, without any known cause, then injury to the fetus was present in the prior delivery. For example, it can involve any nerve injuries, or sometimes even there can be a CP child, okay, or there is a history of stillbirth or IUD. So, in all these cases, okay, when there is a history of all these things in the previous delivery, then you have to think about cephalopelvic disproportion, right? Next, we will see about one more syndrome, that is dystocia dystrophica syndrome. So, what is this dystocia dystrophia syndrome? Okay, so what is this syndrome? Here, the woman is going to be obese. Okay, so there is obesity and there is short thighs. Okay, and this woman will be mostly having an android pelvis. Okay, so this combination of obesity with short thighs and android pelvis is known as dystocia dystrophica syndrome. Clear? Right. Now, we will see these are all the maternal causes so far we have discussed. Okay, still the fetal causes are remaining. So, if we see the fetal causes, yes, it is going to be over, children. Please listen to this. So, fetal causes include macrosomia. Okay, few known causes are known. Macrosomia, or there can be malposition like occipito-posterior position or transverse lie. Then malpresentations also. What are the types of malpresentations? See, bro presentation, breech presentation, like this, because in bro presentation there is going to be the largest diameter of the fetal skull that is going to present, right? So, it is going to be the mental vertical diameter which is around 14 centimeters. So, when this much long diameter is going to present, then definitely it can lead in cephalopelvic disproportion, right? And then if there are any congenital anomalies, okay, congenital anomalies like hydrocephalus, okay. Then if there is fetal goiter or there is cord around the neck or there is conjoined twin gestation. Clear? We will see some other few causes also. So, other causes may also include wrong dates, prematurity and placenta previa. Okay. I hope we have included each and every compartment of the factors that are going to contribute to cephalopelvic disproportion. And remember, cephalopelvic disproportion has a different definition where there is no compatibility between the fetal head and the maternal pelvis, whereas contracted pelvis is different, right? The contracted pelvis is one in which the diameters at various levels of the pelvis are going to be reduced than the normal. So, don't ever confuse between cephalopelvic disproportion and contracted pelvis. Clear? Yes. Okay. Now, when there is cephalopelvic disproportion, how will be your examination findings will be? So, on examination, especially general examination when you are doing, okay, when you are doing a general examination, what are the findings you may find? The patient will have a short stature, okay, that is less than 146 centimeters can be there. Then sometimes she may even have a gait abnormality, like she can have a limping gait or waddling gait. Then she can have, suppose if you inspect for the lower limbs, there can be shortening of the lower limbs. And finally, when you do a spine examination, there can be kyphosis or scoliosis. Clear? Right. Now, we will see the next one. that is about abdominal examination. So, when we do abdominal examination, there is going to be pendulous abdomen, as we have already seen, right. So, there can be pendulous abdomen because of, what was the cause we discussed? Yes, very good. It is going to be due to high assimilation of pelvis, or sometimes due to inlet contraction also. Clear? And then you have to palpate for the abnormal positions like occipito-posterior position, and third option you can do is, you can do one method of inspection, method of palpation, that is known as Moyer's head fitting method. See, this can be used as a screening method for cephalopelvic disproportion. Okay, so this can be used as a screening method. However, it is difficult in the following patients, like when there is obesity, or when there is floating head, or when there is deflexed head. Okay. So, what you have to do is, you have to ask the patient to empty the bladder first, then patient should be kept in a dorsal position with thighs and knees semi-flexed and adducted. Now, what you are going to do in this position is, you are going to keep your left hand like this, and you are going to hold the fetal head, and with the right hand you are going to keep the right hand's thumb and the index fingers over the pubic symphysis. Okay. So, you will be just pushing the fetal head down into the pubic symphysis and see. Okay. Into the pubic symphysis means into the pelvic inlet and see. Okay. So, that time if you are able to see, so that is I told you, left hand over the fetal head, right hand over the middle and index fingers. So, head will be pushed down. So, what happens? There can be three chances, right? So, there can be no CPD, or there can be a mild CPD, or there can be major degree of CPD. So, how will be identifying with this test? So, in no CPD, what happens is, head will be pushed, okay, into the pelvis. Okay. Now, here in a mild CPD, head will get flushed with the pubic symphysis. Whereas in major degree of CPD, yes, very good. So, you will be having overriding of head over pubic symphysis. Clear? So, this is about abdominal examination. After doing abdominal examination, definitely you are going to do a pervaginal examination, and to assess CPD, you have to do it as a abdominopelvic examination. Clear? So, it is an abdominopelvic examination that was given by the scientist Muller. Clear? So, we will see these things. So, as usual, you have to ask the patient to empty the bladder. Then, the woman should be in the dorsal position. Her thighs and knees should be semi-flexed. What you are going to do is, your left hand, as usual, left hand grasps the fetal head, and now since this is an abdominopelvic examination, your right hand should pass through the pelvis pervaginally, and you will be using the middle and index fingers. Okay. and they should go till the level of ischial spines. Clear? So, after this, the thumb should be kept over the pubic symphysis. So, all these 5 steps should be done, right? So, this is how we are going to examine. So, this is the left hand, okay, and this is the right hand. So, you are able to see your thumb, index and middle finger are going through the vaginal route and the thumb is kept over the pubic symphysis, okay. Now, we will be trying to push the fetal head as we have done in the abdominal method. So, we will have 3 interpretations again. So, the interpretations of Muller method include may include no CPD, that means they can be pushed up to ischial spines itself, okay, and there is no overriding of the parietal bones over pubic symphysis. Then, if you take mild degree CPD, they are pushed little but not up to ischial spines. Clear? So, what happens is that the parietal bone flushes with pubic symphysis. And then you have major degree of CPD. So, major degree CPD means you will have that the head cannot be pushed down, or yes, there will be overriding of parietal bone with pubic symphysis. Clear? Right. Now, we will see how about the pervaginal examination alone. Okay. So far, we have done the abdominopelvic examination, that is known as, yes, Muller method, right? Now, we will do pervaginal examination. So, pervaginal examination. See, while doing pervaginal examination, it is ideal that you should explain the procedure first. Okay, procedure should be first explained, and you should get the consent also. Then, as usual, definitely we are going to empty the bladder. Then, aseptic precaution should be carried and it should be done gently. Usually, CPD assessment is best when done after onset of labor. Okay, best after onset of labor. Clear? Now, we will see pelvic assessment. Okay, how we are going to assess the pelvis. So, what are the features we will get? So, when we see pelvic assessment, so while doing pelvic assessment, you have to check the following features. Okay, so you have to check how was the sacral promontory, okay, whether it is reached or not, okay, and then you have to check the bay of sacrum, whether it is well curved or not, okay, and the third point is you have to check whether the sacroiliac joint admits 2 fingers, okay, yes or no. Then you have to check for the pubic symphysis if there is any beaking present, okay, beaking present, yes or no. Then you have to check for pelvic side walls, that is whether it is convergent or parallel. Then you have to check for the ischial spine's prominence. Yes or no. Then you will check for subpubic angle, whether you have an acute angle or you have an obtuse angle. Then you have to go for checking with your clenched fist. Okay, you have to check for your 4 knuckles or admitting the space between the ischial tuberosities. Okay, for this also we will give a yes or no answer. Then you have to check the coccyx, whether it is mobile or tipped. Okay, so ideally these are the questions you have to check for while doing a pervaginal examination. Okay, and if you get the answers like the sacral promontory is reached easily, and the bay of sacrum is not well curved, and then sacroiliac joint does not admit 2 fingers, and pelvic and in the pubic symphysis beaking is present, yes. Okay, so you have to click all the answers which is going to reduce the pelvic diameter. Okay, so pelvic side walls are convergent, especially ischial spines, or the ischial spines are prominent. Okay, ischial spines are prominent or not. So that means the ischial spines prominence is there. Okay, that will reduce the diameter, right? Then the subpubic angle is going to be acute. That is going to reduce the diameter again. Clenched fist, no, it doesn't allow 4 knuckles. Allowing 4 knuckles in the ischial tuberosities is going to give you the adequate pelvic diameter. Okay, and coccyx, if it is tipped, then it is again going to reduce the pelvic diameter. So these are all the findings you have to find it while doing a pervaginal examination. Clear? Right. So we have something called as clinical pelvimetry, where we have to measure the pelvic diameters, right? So in pelvic clinical pelvimetry, we have to measure the diagonal conjugate. Okay, so diagonal conjugate, because it is the only measurable conjugate in the anteroposterior diameter of the inlet of the pelvis. So it is from the lower border of pubic symphysis to the sacral promontory. Okay. So what you are going to do in this is, you are going to do a pervaginal examination by inserting your index and middle fingers of your right hand into the vagina, and you have to go and you have to touch the nearest possible diameter, nearest possible point on the sacral promontory. Okay. After it impinges with your left hand, see the left hand, I just showed the sacral promontory. So it is touched the sacral promontory. Now I am using your left hand to mark, suppose this is the level I got. Okay, so at this level I am getting it touched, means I will be just marking it with a pen, and I will be taking, and I will then using a scale I will be measuring the distance between these 2 points. Okay, so this is the ideal diagonal conjugate, and we all know diagonal conjugate doesn't have any obstetric significance. We have to find the obstetric conjugate diameter. So what will happen means, how you will be finding an obstetric conjugate? You have to reduce 1.5 to 2 centimeters from the diagonal conjugate. Clear? Suppose the normal obstetric conjugate is around 10.5 centimeters. If due to any reasons this is less, means then there can be a chance of cephalopelvic disproportion. Clear? Yes. Now, what are the other methods? Okay, so far we have discussed only the examination methods. So other investigations like USG can be done, where you can go for fetal weight estimation, or sometimes BPT can also be estimated, and BPT more than 9.4 centimeter can suggest there can be a chance of cephalopelvic disproportion. And then you have to see the relationship of the head to the pelvis also. Clear? So all these things you have to remember. And another option is, you can even try MRI. So this can assess the pelvis in all planes, and It can even give information on soft tissues, but it is not routinely done. Okay, right. Now, we will see how we will be managing cephalopelvic disproportion. So, management, suppose if the fetal head is small and maternal pelvis is going to be big, then you can allow vaginal delivery. Suppose this is one option. Second option is if the fetal head is very big and maternal pelvis is small, then definitely you can offer them cesarean section. Clear? But if you are not sure about the measurements, then you can even plan for a trial labor. Clear? So, what is this trial labor? Okay. So, trial labor is something we are going to give we are going to try whether there is any possibility that the labor can happen naturally or not. Okay. So, what are the indications of offering trial labor to a woman in labor means? When there is minor degree of CPD. Already I have said when it is going to be a major degree, we are going to take it to a cesarean section. When there is only minor degree of CPD, and second point, you have to check for the fetal well-being also. It should be of the average weight, okay, average weight fetus. Then there should be no obstetric complications, okay. Obstetric complications are totally nil, okay. So these are the indications, means these are the criteria you can tell. Instead of indications, we can keep it as criteria. So these are the criteria for giving trial labor. And then we can say that this trial labor depends upon three factors again. It depends upon the uterine contractions, moulding of the fetal head, and yielding of the bones and joints. So, how to conduct? You should get an informed consent. You should start the mother on IV fluids. So, with this we will be securing the IV lines, right? Then you have to make sure if the mother needs an epidural analgesia. Then definitely you should maintain a partogram. Even oxytocin augmentation can be considered. You can go for considering applying vacuum or forceps if needed. Then definitely you are going to do a active management of third stage of labor. Clear? So, what are the favorable signs that it can end up in a natural labor? Okay. So, if there are good uterine contractions, the baby is in a occipito-anterior position, there is early engagement of head, and it is closely applied to the cervix. That is, the fetal head is closely applied to the cervix, and rupture of membranes happened after cervical dilatation. Okay, so all these are favorable signs for normal labor. Okay, Then if you take trial labor, sometimes it can be successful or it can go for failure also. Okay. So, if it is successful, when it has ended in vaginal delivery or operative vaginal delivery, okay, and if there was a good maternal outcome as well as the fetal well-being is also good, okay, and it is said to be failed when it has ended up in cesarean section or it has ended up with vaginal delivery itself, but there is poor maternal or fetal outcomes. Okay, so both maternal and fetal outcomes are not good. Clear? And then we'll see about the complications that can arise. So, complications for the mother can include there can be PROM, due to that cord prolapse can occur. There can be chances of operative vaginal delivery which will be leading to injuries or lacerations, or there can be chances of postpartum hemorrhage, okay, and chance of infection, dehydration, okay, sepsis can also be there, and sometimes this can even result in rupture of uterus, okay. Then there can be formation of vesico-vaginal fistula. Then what are the fetal complications we can expect? Fetal complications may include asphyxia, hypoxia, intrauterine death, stillbirths, fractures, hypoxic ischemic encephalopathy and cerebral palsy. Clear? So, with this we are completing this topic. I hope you would have understood what is cephalopelvic disproportion, what is contracted pelvis, what are the various etiologies, how we are going to find it during examination, during various investigations, and how we are going to manage it, right? Okay, so until we meet in the next video, keep going, happy learning and take care.